among those stuff, the important things that I should mention are, the blood sampling, then making discharge tickets, taking consent for operation, you know, and a lot of other file work like making llama that leave against medical advice, making refer, discharge on request, refer on request, and being present at the time of morning rounds, evening rounds, and taking patients for pre-anesthetic checkups and getting reports for that. And then also important part that how to track reports of the samples that you had sent earlier. So I'll try to give you a brief, a brief knowledge and a brief concept of how you can, make your practice easy. And I'm not an expert, of course. I'm an intern right now, and I had been posted for 1.5 months in surgery, and there only I learned the blood sampling perfectly. Not perfectly, but initially we were not able to withdraw blood in first attempt every time. Initially it was if the hi, hello there, good evening everyone. How are you all doing? I hope you all are doing well. I'm doing good as well. So I wanted to inform you all that my surgery posting is over. It got over on 19th of July, and right after that, from 20th of July, I have been posted in anesthesia right now, and it's been, I think, 4 days right now. Because I joined on 20 and today is 24th, so it is today was the 5th day of my posting anesthesia, and I got a lot to talk about my surgery posting because that was my first posting, and we learned a lot of things there because it was the first department and our first actual interaction with patients, apart from the history taking and that part that we had been doing since second year. So surgery was a primary department that taught us the primary things of management in ward and a lot of other stuffs. And among those stuff, the important things that I should mention are, the blood sampling, then making discharge tickets, taking consent for operation, you know and a lot of other file work like making llama that leave against medical advice, making refer, discharge on request, refer on request, and being present at the time of morning rounds, evening rounds, and taking patients for pre-anesthetic checkups and gathering reports for that. And then also important part that how to track reports of the samples that you had sent earlier. So a lot of things that we learned in surgery, and although there are a lot of topics and a lot of videos can be made on those separate topics individually, but right now I've decided to make this video completely focused on blood sampling. So I'll try to give you a brief a brief knowledge and a brief concept of how you can make your practice easy. And I'm not an expert, of course. I'm an intern right now, and I had been posted for 1.5 months in surgery, and there only I learned the blood sampling perfectly. Not perfectly, but initially we were not able to withdraw blood in first attempt every time. Initially it was if the vein was very prominent and easy to spot, we used to do it easily, but in patients in whom the veins were not visible, we needed to palpate and locate the vein and then take the samples. And in those patients we needed 2 attempts, or many times more than 2, to be honest. And that's how we learned, and with more and more practice, more attempts, we got better and better. So based on my my experience of 1.5 months, and the we took a lot of samples in a lot of patients every day. We used to take around 3, 4, 5, 6, even more than that on an average. So in 1.5 months it was, of course, more than, we took samples of more than 100 patients. So I think based on that experience, I can tell at least a brief detail about blood sampling from the peripheral veins as well as the from the femoral vein. So for femoral vein we might talk about in another video. In this video we will mostly talk about this sampling from the peripheral veins like middle cubital vein and other veins around this cubital fossa. So let me tell you my experience and how we started and how did it go. So in the beginning, right now the video is 4 minutes and 12 seconds. It might go long, but I get carried away every time, and that's the way I like, because I always try to expand and describe the things, and I just can't wrap up a topic in 5 or 4 minutes. So sorry for that. Video might be long, but it would be worth watching, I think. So in the beginning, when we were posted in surgery, when we joined around 9th of June. So in the beginning, none of us were used to, and none of us were expert or not even good in the sampling. Few of us, they had practiced it in casualty in final year and third year, but most of us, we hadn't done it. I myself had done blood sampling only 5 or 6 times when I was posted in Hummer lab, that pathology lab, in final year, because there is elective postings in clinical and non-clinical department for 1 month each. So my clinical posting was in non-clinical posting was in this pathology. Uh, so I was for a few days I was posted in at Hammer lab. So there we learned blood sampling out of curiosity. No one asked us, our faculty, they didn't ask us to go and take the samples. Just out of curiosity, we tried, and it was very difficult in the beginning. So, and same situation was there in this internship for first 1 or 2 days. So in the beginning we were taking samples, and let me tell you the mistakes that we were making in the beginning. So in the beginning, what we were doing, that we were not fixing the veins properly, and we were not locating the most prominent vein. So uh, you know because of the lack of knowledge and lack of experience, we were puncturing any vein that was visible to us, and because of that we were failing again and again. So first was that we were not choosing vein properly, and second one was after choosing the vein, we were not fixing it. So our needle, it used to in the beginning, we used to think that it is going in the proper side, but as soon as we push the needle forward, it used to get distracted from the course of the vein. So of course, when you try to withdraw the blood, it won't come. And the third mistake was that even though when we used to insert the needle in the proper course of the vein, we used to take it too deep, that it used to perforate the vein all through its depth. So it used to go beyond the veins whole thickness. So again, you need to bring it back a little bit, and when the needle comes in the in the lumen of the vein, then only you can withdraw the blood. So this was the third mistake. And the fourth one was that when there was no prominent veins, when they are not visible at all in the periphery, then we used to take blind attempts without palpating the vein, and we were just guessing the site of the vein, and we were inserting the needle. That was again a big mistake. In the fourth mistake was the very blind attempt, that if you haven't located the vein, how the hell you gonna take the sample from there. So these were the four mistakes, I think. These were the major mistakes, and I'm sure as hell that again the new interns, the juniors after us, they will do the same mistakes again. And this might help us, this might help them to take precautions for this, and use a proper technique. So now, how did we overcome these mistakes? So first of all, look for the veins in both the arms, in both the cubital fossa of left and right arms, and then you spot the most prominent, most dilated vein. And once you find it, so choose that vein, and then what do? You if you're right-handed, then take your left hand and put it below that forearm of the side side of the arm that you have chosen, left or right. So you put your the less dominant hand below the forearm, right under the cubital fossa, and use your thumb to fix it. And all those aseptic precautions, of course, you have to sterilize the area, take aseptic precaution, that with a spirit in cotton, whatever that part you already know. I'm skipping that part and coming directly to the the main part. Okay, so you use your thumb of that left hand to stretch the skin, and that's how you fix it. And of course, you're using that tourniquet, and you're asking the patient to make a fist with their thumb inside the fingers. Okay, all these things. So you choose the vein, then after choosing the vein, you tie the tourniquet, then you choose the site where you are going to insert the needle, then you took the safety precautions and you clean the area with spirit and cotton. And after that, you use your thumb of the left hand to stretch that skin right under that vein, the site where you're going to insert the needle. Just beneath that, put your left thumb and pull it towards you, so that the skin would get stretched, and after stretching that vein, it would get fixed, and it will not deviate while inserting the needle. Now you ready your needle and insert it. So while inserting the needle, I think you already know that the bevel should be directing upside, okay, upward, so that when you insert it, it will be open, it will not get closed by the contact of the skin and the lumen. So keep the opening of the bevel upward and then insert it slowly. And while inserting, your angle might be around 30 or 25 degree, or maybe 35. But as soon as you have inserted your needle, then you try to bring it in parallel to the vein, so that the needle, it would be lying inside the lumen. Otherwise, if you making your angle big, like 40-45 degree, and you're inserting the needle further and further, you will perforate the vein, and your needle will end up beyond the vein, and it will perforate the whole thickness of the vein, and then the blood won't come. Okay, so this is the basic technique that we have learned. For myself, I learned this. And then, if this is the right here, you are going all the way correct. But even though if the blood doesn't come in your syringe, you see the needle, you will quickly spot the blood coming a little bit in the syringe. Then you know pull your plunger forward, not forward, towards you, and you draw the blood. But even though after until here, if blood doesn't come, you don't have to to take out your needle completely out of the skin. Don't do that, because again you need to puncture the vein, again you need to insert it. So right here, wait, you just adjust the distance, take it a little bit. You might have perforated the vein, so take it a little bit backward towards you, so that the needle will lie in the lumen once again. And then keep observing the needle. As soon as the blood comes, stop there and stabilize your needle right there, because this is the site exactly where now your blood is going to come, and you can take your sample from there. So take it a little bit back towards you, then again look for the blood to come. If not, then adjust the angle a little bit upward, little bit downward, increase and decrease the angle. And if you think that you haven't inserted your needle deep enough, so you can insert it a little bit more deeper. But remember to keep it parallel, so that you won't perforate the vein through all its thickness. And what else? And yeah, and one more thing, one more trick that you can apply is that once you inserted your needle, and if the blood hasn't come in your syringe, what do? You pull the plunger towards you, create a vacuum in the syringe, and then keep adjusting the needle, the angle and the distance. And as soon as your needle lies in the lumen of the vein properly, immediately the blood will come, and you can stop right there. So you have to adjust slowly, because if you adjust quickly again and again, you won't be able to stop at the right place at the right time when your blood will come. Then again you will miss the spot. So adjust slowly, and as soon as the blood comes in your syringe, stop right there, fix the needle. The thumb that you were with the thumb that you were stretching the skin, now use that thumb to fix your needle, and then with the right hand you pull the plunger further and further towards you, and the blood will fill your syringe. So this is the whole thing about sampling from the peripheral veins. And one more thing is that you don't always have to take the sample from the cubital vein, middle cubital vein. There are other veins as well on the medial and lateral to it. If middle capital vein is not visible but others are visible and more palpable, then you can go for them. It doesn't matter that you always have to take from that vein. Even you can take samples from the wrist, from the hand, anywhere where you think the vein is more prominent, more fixed, more dilated. You can take samples from there. And what else? And now when the vein is not visible at all, then what do you do? So what we used to do is that, personally, let me say that, whatever I did myself, I will tell you only that. So what did I do? Whenever the vein was invisible in both the hands, so I used to palpate the vein. And you palpate the vein in that same area where you expect it to be, in front of the cubital fossa. So you feel that rebound feeling, that a little bit of resistance is there, tube like structure is felt with, when you press it. Then as soon as you leave it, it rebounds so you can feel the vein like that little bit of resistance is there and little bit of that rebound consistency is there. So once you spotted the site, so you palpate it a little bit upward, little bit downward, so that you can assume the course of that vein in the direction. And then you can insert the needle in that proper direction, so that your needle would be properly in the lumen of that vein. And this palpating trick is very very essential, because many of my batchmates, I have seen them, whenever they found a patient with not visible veins, so they directly used to go for the femoral option. And as a teachers have told us that taking samples from the femoral vein is not a routine practice. So I tried to mostly stick to this peripheral vein sampling, and I used femoral vein option only when needed, only when the it was too damn difficult to take sample from the peripheral veins. So this is the palpation method, where after palpating you have to again you have to palpate with both the hands and spot the site where it is most prominent and most dilated, and you choose that site only, because after all you don't want to take more and more attempts. So it's better to take your time and choose the perfect vein for that. And then after that, after only doing this, you take your attempts and insert your needle, because it becomes irritating for us, and it's become more and more painful for the patients, that you're punching them again and again for that damn one sample. And it's also let me be honest, it feels a little bit embarrassing in front of the patient and relatives, that they start thinking that they are still learning, they are naive, and they don't know to take samples. And we have encountered this moment many times. The patient's attendant, they used to ask us, sir, how you don't know it? Nurses are better than you, and they take samples in one attempt, and you guys are taking in like 2 or 3 attempts for one sample. So send the nurses instead, you don't come for the samplings, like this. And yeah, we have faced, and we all know that was all true. We were still learning. We knew that we were not perfect, we were not experienced, and we faced that, and we got along, we practiced again and again, 2 times, 3 times in one patient sometimes, and that's how we learned. So I think I gave you pretty much a brief idea that how you can make your blood sampling easy from the peripheral veins. And what else? Vials, that red one, purple one, and the gray one. Gray is for estimating the blood glucose, and sky blue color is there for the protein profile. What is that? APTT, PT, and yeah, INR. And red one is for the routine, what is that? RFT, LFT, serum electrolytes, and all the viral markers, HbSAg, HCV, HIV, amylase, lipase, those levels. And the purple one, the EDTA one, it's for the CBC, and also for HbA1c. Okay, and also for blood grouping, for this stuff. And what else? Tourniquet is very important, to tie tourniquet, and also to ask the patient to make a fist, because tourniquet, it stops the venous drainage, not completely stops, but slows down the venous drainage, so that more blood collects in the vein. And the fist, that also helps to dilate the vein, and that that makes your sample collection more easy, because you can withdraw the blood sample quickly, because more blood has been collected in that vein while you tied the tourniquet above the cubital fossa, or depends on the side from where you want to take the sample. So the video is almost of 19 minutes, so I think it would be enough for this one. So we will talk about femoral vein sampling in the next video. And femoral vein, we should not go as a routine practice, we should not do it very frequently, because one thing is that patients are not very comfortable with femoral vein, and especially with the ladies we encounter this thing. We only go for femoral when we can't take the sample from the peripheral veins, and if the patients are too obese, or whatever reasons, for whatever reasons, we if we can't take the samples from the periphery, we go for the femoral. So we'll talk about the femoral vein sampling in the next video. So I hope it would make your job a little bit easy, when you go for samplings from the peripheral veins. Even though if you are practicing right now, or you are going to be an intern, as I told you, I am not an expert right now, I am an intern right now, and whatever I told you is based on my experience, not too long. Of course, I'm still learning. Okay, so see you in the next video then. Take care. Bye bye.